Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Coccyx.
Hello again. How are you today? We have Larry on the table, and we're going to do a sacrum coccyx for you. We've got things pretty much preliminary set up, so let's take a look at the patient. For sacrum coccyx, we're going to do an AP sacrum, we're going to do an AP coccyx, and then we're going to do a lateral, which will hopefully demonstrate both the sacrum and the coccyx. I've set up for an AP sacrum now. We have an 8x10 in the bucky tray, lengthwise, ID to the bottom. Think of the shape of the sacrum. Its base is wider, and it goes to the apex in a V shape, and that's why we put markers to the bottom. The arm marker is moved in just a little bit because I'm going to have about a ½ inch, no more than an inch of collimation all the way around, again, to a lower corner because of the shape of the sacrum here. My tube is angled 15 degrees cephalic. 15 degrees cephalic because the sacrum, we'll focus on this for a second, the sacrum, here's the patient's back, and the sacrum angles down. And that's why we need the cephalic tube angle, so you can be perpendicular to it. Then it curls up with the coccyx, and when we do the coccyx, we will have a caudal tube angle. Okay? I've adjusted the gauge, so I've maintained 40 inches. Gauge says 37 for a 15-degree cephalic tube angle. If you have difficulty remembering the amount of tube angle that you need, a student trick is they've come up with 15 towards the face. The patient's face, 15 degrees. That would be for the sacrum. Part film reference points. Come flat-handed onto your patient. Find the ASIS. Come in from the tummy side. Here's the ASIS. On a male patient, you know, they will be in a gown. You won't have the underwear on, but Larry's pubic bone is approximately right here. The upper part is here. I'm not going to palpate. I can't see it on camera, but that's my estimate. And then the crosshair goes halfway between the ASIS and the upper border of the pubic bone. And the MSP is to the center of the film, and the patient is not rotated. Okay? In a gown, you'd probably be able to see the pubic bone. But for demonstrations, I'm going to double check my positioning. This was just a guess. I cannot tell for sure where his upper border of the pubic bone is. So I'm going to find his trochanters. There's Larry's trochanter. I found it fairly easy, and if you'll recall, it is at the level of the pubic bone, right there. So I can use my ASIS and take a look. I used an alternate reference source to confirm that I was halfway between the level of the pubic bone, the upper border, and the ASIS. So I'm very happy with the centering. If I had a scrotal cup, I would be able to protect his gonads. I don't in this demonstration purposes today. So we're going to make the exposure. Just have your patient take in a breath and blow it out, and you can make the exposure. Have your patient remain in the same position after you make your exposure. Let them breathe. Their body is straight, MSP's to the center of the film. Change film, new cassette. Now, the coccyx is only the size of a postage stamp. So you're going to collimate to a 5x5. The cassette is 10 inches, and you're going to have 5 inches, so 5 from 10, left you 5, divided by 2 edges is 2.5 inches up. So this marker, bring it in about 2.5 inches up. Side to side it will be 5 inches. This is 8. So 5 from 8 is 3. Divided by 2 sides of the cassette, move that marker in 1.5 inches. That's the process to calculate how and where to put your marker. We need to reverse the tube angle 10 degrees caudal, 10 to tail. That was the student trick, 10 to tail. Officially it's 10 to caudal side. So 10 degrees, adjust your SID, realign your tube so it exits to the center of the film. Camera see that? Transversely center the tube again, column A to 5x5. Push the cassette in. MSP should be to the center. And now find the ASIS right here. And the central rate enters at the level of the ASIS, exiting to the center of the film. Patient is not rotated. MSP's to the center. ASIS exiting to the center of the film. You can make your exposure. Patient takes a breath in, blows the breath out. Don't breathe, don't move, make your exposure. For both the AP sacrum and the AP coccyx, is the anatomy to the center of the film? Did you include all of the sacrum? Did you include all of the coccyx? To determine rotation, you look at the pelvic inlet. You're going to be able to see the obturator foramen. If you'll recall, they need to be the same distance on both sides. If one is bigger and one is smaller, that means the patient was rotated. And if one is smaller, try to remember, what does that mean? Which way was the patient obliqued? If the right side is smaller, what oblique was that? Slight RPO. Okay? You'll remember that from your discussions on your pelvis exam. You can also look at the ischial spines. They should be equally seen on both sides. If one is more dominant than the other one, that means that side was closer to the film. So you're looking at the overall shape of the pelvic inlet. The structure should be equal distance to the lateral edges. Look at the obturator foramen. Look at the ischial spines. Okay. We're going to turn the patient into a lateral position now, and I think I can talk while we do this, and we can save some explanation. Have the patient face away from you. Put a sponge between their knees for comfort. Get them straight on the table. You want a perpendicular beam, 40 inches to the bucky. I'm getting the tube approximately centered over the sacrum area. I'm going to switch to a 10 by 12 cassette, and I will use a lead blocker behind the patient, just like we did with a lateral lumbar spine. If you're using a lead blocker, you put the L marker on the anterior wall, and I'm keeping my ID blocker consistent with my APs. I moved the L marker in because I'm going to have approximately 6 by 12 inches of collimation. Again, the tube and the film are lined up. Patient is in a true lateral position. I'm focusing on his shoulders and the small of his waist, making sure he's in a lateral position. Now I'm going to find the crest and the film's edge. Film's edge will be 1 inch above the crest. Okay, here's the film's edge, 1 inch above the crest. But I like to look at the bottom edge of the film too. Okay, here's the bottom edge of the film. And you can look at the patient's buttocks. And in a gown, Larry's pants are causing us a little problem here. But if you see that bottom edge of the film and you're x-raying tabletop, that should be an indication that you're too low. You need to be up over the sacrum and coccyx. Okay? But in today's demonstration, we're just fine. The film's edge is 1 inch above the crest. I look at the bottom edge of the film. I'm not x-raying too much tabletop, so I'm satisfied with that positioning. Front to back now. The sacrum is very posterior, so I know I need to go that way. And I want 12 inches by approximately 6. And I'm going to I want to find L5. You already know how to find L5. 2 ways you can do it. You can ASIS and a couple inches back. We also taught you can find the trochanter. Feel for the trochanter. L5 is slightly behind the trochanter, about 1 inch. Then you can palpate the posterior wall of the patient. This will help you if there's a lot of adipose. It'll help you give a judgment call. And the crosshair, this crosshair here, should go right between these two hands in a vertical plane. So if you look at this demonstration, I need to scoop my patient a little further away from me. Not much, but a little further away from me. And the table won't move, so we just will slide him just a little bit. There you go. Okay, again, here's the trochanter. L5 is just behind it, or you could use the 2 inches behind the ASIS. Find where L5 is. That's the very anterior portion of the sacrum. You can feel or palpate the posterior aspect of the sacrum, and this crosshair should come right down between those. And I think the camera can see that relationship there. Bring your lead blocker in to the field, but not into the shadow, because there's not a lot of adipose tissue back here on this patient. So we don't want to put this lead blocker into the shadow. Somebody who's 300 pounds, this strip could go into the shadow a little bit because they have a lot more adipose buildup. Again, I'm centered to the film, so I can push this in, and the patient didn't move. They're still in a true lateral position. They're comfortable with the sponge between their knee, and I may make my exposure. Remember, your left marker is on the anterior wall. And I'm going to have my patient lay there for a minute because I'll do a little bit of film critiquing here. If you've shot this x-ray and the patient's in a true lateral position, the acetabulums, this one and that one, will be on top of another. This one, of course, will be bigger because you have OID, but they should be in the same vertical plane. If the patient is not lateral, like that, the acetabulum, instead of being one on top of another, one is shifted forward and one is back. Okay? You don't want anterior and posterior displacement of the acetabulum. They need to be one right on top of another. Now, any patient that goes into a lateral position, the pelvis tips. Women will tip more than men. So the acetabulum in this level, you would think that they would be this way in the same vertical plane, but because the pelvis shifts, one will naturally be higher than the other. So we're not concerned if they're not aligned vertically. We are concerned if one is forward as compared to back. Make sure all anatomy is on there, and most of the time, one exposure for a sacrum and a coccyx lateral position will give you good density for both the sacrum and the coccyx. Once in a while, however, because the patient habitus, if the density is appropriate for the sacrum, the coccyx may be burnt out, may be too dark. Or vice versa, if the density for the coccyx is ideal, your sacrum might be too light. In those cases, it will be necessary for you to take 2 images. Your positioning is usually not a problem, but the technical factors might be just because of habitus. And then you would just do 1 of 2 and 2 of 2 in order to get decent density for both the sacrum and the coccyx. And that's our lesson for today.